Welcome back to another episode of Single Payer Radio. I'm Paul Hoppy, broadcasting on the Forward Radio Community Network, WFMP 106.5, and our program airs on Monday at 2 p.m., Tuesday at 7 a.m., and Wednesday at 11 a.m. And we also stream our show on SoundCloud. The show is a project of Kentuckians for Single Payer Healthcare, affiliated with the Kentucky chapter of Physicians for a National Health Program. We produce this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, publicly funded, single-payer healthcare system for everyone. The views and opinions expressed on our show are those of the speakers and not the station. Before we get started, I'd like to remind everyone that we are in the midst of our annual fund drive and also celebrating 8 years of presenting our unique programming that you can only get here on Forward Radio. Get the whole scoop on the festivities by going to forwardradio.org. And also, while you're there, hit that orange donate button. We are an all volunteer run organization, and your donations are our sole source of revenue, and we depend on you to keep us on the air. And don't forget to stop by our 8th birthday party on April the 5th to help us celebrate. And now today's program with Doctors Mike Flynn and Gene Shively. Mike, why don't you get us started?
Thank you. This is Michael Flynn, retired surgical oncologist from the University of Louisville Surgery Department. Let me begin with the usual disclaimer. Any comments I make represent my personal views and do not represent the views of the Department of Surgery or the University of Louisville. Gene?
I'm Eugene Shively. I'm a retired general surgeon from Campbellsville, Kentucky. I practiced in rural Kentucky all my life. Mike and I came together at one of our meetings to decide to do this. Anything I say does not represent Taylor Regional Hospital nor the University of Louisville Department of Surgery.
Our topic today is UofL Healthcare and UofL Hospital. And this is especially an important topic because the ability to get access to health care in Louisville was much improved when UofL stepped up and took over health care with Jewish Hospital with the collapse of Kentucky One and the Catholic Health Initiatives. And we have a special guest who has a special interest and expertise in these areas. Jason Smith is the Chief Clinical Officer of UofL Health. He's a professor in the Department of Surgery, Chief of Division of General Surgery. He got his medical degree, did a residency and a fellowship, a residency in general surgery, a fellowship in critical care at Ohio State University. Jason, we appreciate your willingness to come on and talk about these issues. What we've done with most guests in the past, we give them an opportunity to make whatever comments they'd like to make about the topic, and for as long as I'd like, and then the conversation will begin. So the floor is yours.
Well, thank you, gentlemen, very much, and I'm happy to be here and happy to be on the program. I'll make my own disclaimer. I'd love to talk about these things. I'd love to talk about, the story of UofL Health and healthcare economics. Not everything I say will be the opinions of the University Hospital, University of Louisville, or the like. They're my opinions. And it's great talking to two mentor and friends I've had through the years, and glad to be on the program. One of the things that I've said for a bit is that I think 2025 is going to shape up to be a huge year in changing healthcare, both for the better and for the bad sometimes. But I think you're going to see, probably since the advent of the Affordable Care Act, going on, 12, 13 years ago now, the first time that we're going to see some major shifts in the way healthcare works, be that from a payer perspective, be that from an access perspective. And I think it's important for people to understand that, the system that we have really has been put together and is uniquely American. And that's the one thing that I oftentimes, hear people talk about is, oh, we need to be like this or like that or compare us to different countries. But the simple fact of the matter is healthcare and healthcare finance and economics here in America are uniquely built based upon what we had to deal with as we develop this system, be that through the Industrial Revolution or tying it to working during the Great Depression or tying it to healthcare benefits following World War II and the advent of Medicare and Medicaid during President Johnson's terms. Those are the things that we are working with. And by and large, the way we are dealing with this and managing healthcare finance, access, and care really is all built upon things that were put together in the 30s through the 60s. There was about a 30-year period of time there where the infrastructure was built for the care of patients and the payment of bills for those that could not pay for themselves, as well as the insurance industry was started. And so we have grown from that, obviously, but really, even with the Affordable Care Act, we didn't add, change, or do anything differently than we already had on the table. We simply changed the plate sizes, the portion sizes, and did a few extra things with what we had. So it's always interesting to come on and talk about, what we did here at U of L and U of L Health, the way we came together, and looking at that in kind of the greater perspective of what healthcare finance and healthcare economics look like in the United States. You can compare and contrast that around the world. And I truly believe that the very best healthcare you can get in the entire world occurs here in the United States. That's why people come from around the world to be a part of our healthcare system. It's just that it's messy. And, it's a uniquely American thing. It was built messy. It remains messy. And I think that's just indicative of the melting pot that we are of a country. And so we put a lot of different ideas together and we have to figure it out. And so I'm glad to talk about that today and talk about our situation and appreciate you all having me on.
Jason, one of the great things that UofL Health has done is when Kentucky won, was in big trouble, and Jewish Hospital was on the verge of being bought by an equity company. University of Louisville took a big risk and bought Jewish and St. Mary and Elizabeth and Our Lady of Peace. Can you tell us a little bit about that and how you were so successful in doing that and what you're doing now at UofL Health?
Yeah, happy to. Look, go in the Wayback Machine here. Really about this time, 2019, we had started to look at what would happen if Kentucky won, CHI at the time, got rid of the Louisville market assets that they had, which is what they were looking to do. It really wasn't integrated into the rest of their national healthcare enterprise. They were merging on a national level, and it was going to be an area that they did not feel they needed to be in. So they were looking for private equity investors and other folks. And I think, you quickly when you got into those discussions, you quickly realized that, they were going to close a number of these hospitals. In particular, Shelbyville would be closed and spun off, and Jewish Hospital would be closed downtown. And when we looked at it from the university side of things and started talking to people in the community, the physicians, the board at U of L at the time, um, we came to realize that as our mission for a healthcare organization and the role that University Hospital and University Medical Center has served in this community for 200 years was to afford access to people that didn't have access. And if you close one of the major downtown branches of healthcare that represented at the time around 400 plus patient beds, um, you were going to cut off access to the folks that were most vulnerable. And so it became somewhat of a mission of ours to find a way to keep this open and bring us into a single academic healthcare organization. And with the support of the board, the support of the state government, we were able to do that. We in November of 2019, we merged the assets of what had been, University of Louisville Physicians, University Medical Center, which was U of L Hospital and the Brown Cancer Center, with what was the Louisville market of Kentucky One, which was, Jewish, Mary and Elizabeth, our freestanding medical centers in Shelbyville. And we became U of L Health. And then, we started the job of integrating everyone. And I joke that at the end of January of 2020, we finally got the physicians all merged together into University of Louisville Physicians. On March 15th of 2020, we promptly shut down all of our doctors' offices and hospitals because of the COVID pandemic. Um, and really, we took care of hundreds, if not thousands, of COVID patients, particularly during the first, wave of COVID that hit really in that March, April, May timeframe, and then later in October, November timeframe, which was predominantly done. A lot of them were taken care of at Jewish Hospital. We became a referral center for the sickest of the sick, of those that had COVID, particularly those early strains, which were more, serious. We were putting people on our extracorporeal oxygenation, our ECMO circuits. We were the only one in the region to be able to do that. And we were serving the community. And I honest, as a community member, I shudder to think what would have happened to those folks during that time if Jewish had not been open and we did not have those facilities because, you know, everywhere was closed and everywhere was having these problems. And, I will give credit to the University of Kentucky. They really stood up and did a lot to help the community out, just like we did. And it really made a difference. And so, that was the first time or feeling that those first few months of seeing, wow, this could have gone a whole lot different. Now, the COVID pandemic, I will tell you, has helped us in merging. We became a system much faster, I think, than we would have if we had not had the COVID pandemic. But it slowed some things down for us too. And some of the foundational work that you would normally do of bringing two, big healthcare systems together, we're just now getting to, 5 years on, if you think about it. We're doing some of that work right now, and it's been great. We've been able to integrate the physicians well. The system itself has been a success. And I think that goes back to putting it in the hands of the community and those in the community that really want this to work, and tying the research ideas that we have at U of L with our dedication to patient access and patient care at U of L Health and University Hospital, and everything that Jewish Hospital stood for decades prior to us taking it over. So a little bit of serendipity with timing, but I'm proud of the work we did and proud of bringing them together.
Well, Jason, it's my understanding, and I think the President Ben DePuty deserves a lot of credit for. And let me, the way I understood this, and ask you to comment on it when I'm finished, is that the assets of Kentucky One were acquired by an assortment of grants. There was a $50 million 20-year loan from the Kentucky Economic Development Finance Authority, half of which was to be forgiven if a university met the terms of employment and service to underserved areas. And then the Jewish Heritage Fund and St. Mary's Foundation put another $50 million up. So is that a fair statement? Because I think Dr. Ben DePuty kind of left rather suddenly after all that was somewhat surprising, but I think she did a first-class job putting the finances together that were the foundation of being able to take over the Kentucky One assets.
Absolutely, and I'll give credit to President Ben DePuty and really the board at that time, at U of L. Was really working behind the scenes to help support this endeavor, not just within our community, but also within the government. And you mentioned the Kentucky Economic Development Fund loan to help purchase this. One of the great parts of this is we've paid that loan back in full already. We finished our final payment this year, so we've been able to pay that money back instead of taking 20 plus years. We did it in 5. And so, that's just indicative of, what it means to invest in this system. And that's really my point about the community partnerships. One of the things that private equity, and I was, when you talk about healthcare economics, when we're looking to turn a profit on patient care, that money comes from somewhere, and that typically means we're going to do certain things to maintain that money going to somebody. One of the great things about being the nonprofit system and a community-based system is that gets all returned to our healthcare system. And so for us, it's been great because that's gone to the University of Louisville, and U of L Health in order to increase the care that we were able to provide. And you've seen that with the growth of our healthcare system following this. And so I think the foresight of the folks in the community of seeing how important this was and what this meant. And I think, the Jewish Heritage Fund in particular, they had pulled the money out of that system prior. And then they were returning some of the money into the system to try and help it now that we were taking it over and keeping it within the community. So I give them credit for having that foresight and being a part of that solution for us, for sure.
This is, in my opinion, this is a really good example how a not-for-profit healthcare system can work. Because when you think about the acquisition of hospitals, healthcare systems, physician practices by private equity firms, and the negative effect that has on patient care, this is a really good example. Now, we've had a few people on the program who were from the Jewish system, and they were really very complimentary about how they were literally incorporated into the system. So could you talk a little bit about the process? I mean, how did you, I mean, it went so well. How did that happen?
Well, yeah, I mean, I will tell you that by and large, from a physician perspective, these were folks that we had practiced with for decades, and from a physician and a patient perspective, oftentimes they were caught in the middle of machinations that had nothing to do with them, right? I mean, the physicians were trying to do their best to care for patients. The system wasn't working for a lot of reasons. And, it was important for us to let, the physicians know that, we recognized how important they were. And again, these were folks that we had worked with for decades. They often were part of our teaching program already. I'll use cardiology, for example. Our fellows in cardiology are rotating through and we're working with the physicians at Jewish Hospital at the time as much, if not more, than they were oftentimes working with our folks at University Hospital from an educational perspective. So they were already fulfilling, roles within our healthcare system that would traditionally be filled by professors or associate professors and the like. And so, rolling them in was a very natural phenomenon. I mean, it was something that the physicians themselves cared about, and two, we wanted to make them feel a part of our organization. And so bringing them in, that was one thing that we did is we gave them a voice on the ULP board. So, we have our group, it's called a community medical group. It still exists. Some of them have migrated into the departments now, but a lot of them exist in the community medical group still. They have a voice on the ULP board to help figuring out how we're going to run our physician practices. We have them have a voice in all of our hospital, committees. We don't say, hey, you have to be in a department or you have to do this or you have to do that. And we recognize the importance of the role that they serve within those places that they are dedicated to taking care of patients in. And so that was one. And I think the other thing that we really worked hard on is, I went out and visited almost every practice location that we had at the time that we were bringing into ULP, so that they could see the faces of the individuals that were trying to make this happen and tell the personal story of why it's important. And I think it's easy to resonate when you've got, a physician walking into an office and explaining to you how important it is that we keep that office open and how important it is the access at, our urgent care over on Virginia Avenue is. It's one thing to just put a building up. It's another thing to step over there and explain why it's so important and what we're trying to do. And the ideas of caring for people resonated. And I think that from our perspective has been, the uniting front for the physicians is that, at the end of the day, you can talk all the numbers you want, but there's a patient on the other side of that, and they're in your office. And so it's that person-person, physician-to-patient relationship that we've been working really hard to protect and foster across the organization.
Wayne Tuxen was one of the individuals who came on. He's got his own television program, and he was really very complimentary about how that process went. And as you know, Wayne, he can he can have a lot to say one way or the other. Gene, you want to go ahead?
Did you roll in St. Mary and Elizabeth and Our Lady of Peace in the same way? And all the people working there came on the clinical staff at U of L?
Yeah, absolutely. And what, the other thing that we did, we kept all of the Kentucky One physician group and we brought them into ULP. But the other thing we did is there are still a few folks that are community-based physicians that work at those organizations, Mary Elizabeth Jewish and the like. And we didn't close down the medical staff, and that's the one thing that, a lot of places will come in and take over and say, you're doing it our way or you're out. We've tried not to do that. And we've maintained an open medical staff at those areas and give people the opportunity to practice there if they want to. I will tell you, I think the ULP physician group is probably the best around, but if someone wants to maintain their own practice and work in our facilities out there, we do our best to do that and foster that. And we did. We went to Mary and Elizabeth, talked to them. We talked to the folks at Peace. We went down to the medical centers at South and up at Northeast and talked about, kind of our plans and what we were looking for from an expansion perspective. And we even talked about, what would become South Hospital of saying, hey, this is something we really want to look at. We think Bullitt County needs a hospital. And we began to do the legwork very early about saying, hey, we want to put a hospital down here. It's, one of the biggest growing counties in Kentucky. It's the largest county in Kentucky that didn't have a hospital at the time. And so for us, talking about expansion after they had seen so much contraction over the 3 to 5 years preceding that, was a bit of a breath of fresh air for folks, I think.
Now let's. I'd like to change the topic a little bit and talk about Medicaid. Now the ideological geniuses in the legislature, the national legislature, as well as in the Kentucky legislature, seem to be intent upon extending the tax cuts to the rich from the first Trump administration by defunding Medicaid. Now, I may be correct in this. You can correct me, but it seems to be my understanding from when the first Governor Beshear expanded Medicaid, the difference between non-paying and paying patients at U of L Hospital went from 20% down to 5%. Now, whether that's correct or not, it's just my memory, and at my age, my memory is not as good as it used to be. But give us an idea of what kind of an impact either some kind of work restrictions or some other Medicaid defunding activity would have on U of L Health and U of L Hospital.
So I'll be the first person to acknowledge it's a difficult situation. So I've talked to the legislatures in the state and some of the national and about this very problem. And I recognize the fact that there's a finite pool of money, particularly in the Kentucky side of things, and we have to figure out how to best spend it. I will tell you, though, I think personally, the Affordable Care Act changed the landscape of healthcare expectations in the country. If you'd have asked me 10 or 12 years ago if people thought that healthcare was a right versus you had to work in order to get it, I would have said that it was probably people associated healthcare and insurance with having a job. And that's a uniquely American thing. And that came about for a lot of reasons during the Great Depression and came about following, in particular, the Second World War. And so that development is uniquely American. And I think people held that belief, particularly, when I was starting out 15, 16 years ago. Fast forward to today, and I think, the idea that the Affordable Care Act has offered insurance and healthcare coverage to so many, I think that has probably swayed the overall perception of the general population regarding the right to healthcare in the United States. Now, what does that mean for us? Well, one of the things that U of L Health does is we never say no to anyone. So, we accept transfers from all over Kentucky, Southern Indiana, obviously, because of where we're located. Um, we take from Central Kentucky, Eastern, Western. Every once in a while, we will take someone from the borders over in Southern Illinois and even into some areas of Northern Tennessee, less than we would for Kentucky. But by and large, we have a huge catchment area. But what that does is that means that we've got a huge patient population that often are not served by other folks. And we have expanded U of L Health into areas that folks may not have been served previously for lots of reasons. They couldn't pay, there was no reason to have it. To that end, if I look at the breakdown of U of L's book of business, for lack of a better term, about a third of it is Medicare, about a third of it is commercial, and about a third is Medicaid. And so if you look at our breakdown, very, very different from our other hospital systems in the state of Kentucky. And it was a purposeful build out on our part to try and offer those services to folks that didn't have them. If you look at what would happen if we begin to cut Medicaid, it's going to significantly impact U of L Health. And, I've seen all kinds of numbers thrown around, and it depends on what gets cut and what doesn't get cut. But the bottom line is it's going to be hugely detrimental to us being able to afford to continue the access that we have and the services we have for those that are without insurance. And we've already seen that begin to creep up. We had put, the state of Kentucky had put into place a lot of protections for folks during the COVID pandemic for keeping them on the Medicaid rolls. And they have begun to fall off. So we're already seeing somewhat of an increase in folks that are non-paying or don't have the ability to pay. And we offer charity care in a lot of those institutions, right? What we used to do 15 or 16 years ago is we would write that off and say, hey, that's part and partial to our mission. And then at some point in time, the federal and the state's governments would come back with saying, hey, U of L Health, you have done an important job. You've picked up a disproportionate share of these folks that don't have insurance and provided them care. Here's some money to help, fund that. Well, with the Affordable Care Act, we got rid of all of those things. And so we got rid of all those disproportionate share metrics and funding and all the rest of it. So now we're left with no huge backstop for those individuals. And so I know it's a difficult problem, and I know that we do not have unlimited funds. I just think we have to try and look at what are the other options that we have, then taking money away from direct patient care. There's all kinds of ways and all kinds of dollars that come into the healthcare system that aren't directly related to the care of the patients. They don't go to physicians or hospitals. They're not directed to a person on the end. They go to multiple things. And, what does that mean for us? And how do we say, hey, we're going to take some of this money that's going other places and we're going to find a way to reduce healthcare expenditures that way, as opposed to taking it away from doctors and physicians and patients, which is what the Medicaid and Medicare benefits really do. And so I think from that perspective, it's going to be hugely detrimental to U of L Health, but I will tell you, it'll be hugely detrimental to any healthcare system that has tried to step up and work in the conditions that we currently have in place.
I developed a PowerPoint presentation several years ago. I started looking at the cost of medical care in the United States, and what I developed was a gross estimate. And as you know, we spend about $4 trillion in health care, and I figured out that approximately a third of that had nothing to do with actual health care. For example, for-profit, equity, advertising. It goes on and on and
Well,
on.
the for-profit health insurance companies literally take hundreds of billions
Right.
of dollars out of health care for all of those things that don't have anything to do with providing health care.
Right, and if we could do like UofL's done, and all that, the money they do make goes back into healthcare. I think that we could provide a good healthcare system with really with not being a socialized system, or and without increasing taxes. But I
You
don't
know,
think that's going to
I'd
happen
agree.
right now.
Yeah. Yeah. I mean, I would agree with you. I mean, one, I'd agree with you on both parts. I don't think that's going to happen. But I also agree that, every dollar that comes into the healthcare system comes out of a patient's pocket somewhere, either as an insurance premium or taxes to support Medicare or Medicaid or what have you. So all of those dollars go into the system. And I remind folks that every dollar that comes out of that system as a profit for somebody else or to pay for some related healthcare portion of what's going on in the business means one less dollar for taking care of somebody. I mean, and that's just the bottom line. If you look at healthcare economics, the dollars come in from one source and one source only, and that's the patient's pockets. And so it's interesting when you look at the actual expenditure of healthcare dollars in the United States. The out-of-pocket expense for healthcare in the United States is really not different than what you see in most countries around the world. We're pretty consistent in that number. It's if I look at every year annually, we're right around about $1,500 annually is what comes out per household. But if I look at the amount we actually spend, you've got $14,000 and $15,000 being spent on healthcare, and that money is not all going to healthcare. And so that's one of the things that I remind folks is that, your out-of-pocket expenses are not really out of the ordinary. It's just that all the extra money is going to something that's not related to taking care of a person. We don't negotiate, for example, with lower drug prices. There's a huge lobby around that. So there's a lot of things I think that could reduce overall healthcare expenditure without limiting, access to those who often need it most. And the other thing I remind folks is that, okay, if we get rid of Medicaid and we don't take care of folks that need, chronic medical care, they will wind up in the system one way or another because they'll show up in an emergency department or they'll be super sick. They'll have an untreated condition, and it'll cost 3 to 4 times more to take care of them than it would have cost to treat them chronically. So, while it's important to find a way to best utilize the money, I think it's also important to realize that, you know, uh, don't be penny wise and pound foolish when it comes to what some of these costs were going to be. Because if I take someone with cardiac disease or heart disease, they'll eventually show up in a hospital with heart failure or a heart attack, and then it's going to cost a lot. And that's going to have to come out of someone's pocket in order to take care of them.
Well, I hope that that information can get penetrated into the brains of the national and local legislature. Now, there's another issue with the health care in this country that's different from most other first world countries, and that's medical debt. We have almost 100 million people in this country that have some degree of medical debt, and medical debt is the highest, most frequent reason for bankruptcy in this country. So, it is coming out of their pockets, and it does have an impact. And I wrote an article in Louisville Medicine a year or two ago about this, and I did some research to find out about medical debt in other first world countries. And I found one article that indicated in France in 2017 there was one example of medical debt. It really doesn't exist in other countries. So I don't know. I'm just ranting. So go ahead.
No, you're completely correct. And again, It's why I say that our system is uniquely American. And I will say that it's difficult to compare our system to others around the country because they were built differently. They had different motivating factors than what we had when we were building the healthcare and the insurance markets around the United States. Um, and again, that's okay as long as we identify how we want to fix this and stay within our own healthcare organizations and stay within our system. I mean, if we want to do something different, I'm all for it. But, to say, hey, we're going to just adopt what England or Canada or France or Switzerland, that's just not realistic. They didn't develop like we did. They don't have the motivating factors that we do. So let's find an American solution to this because it's an American system.
Well, there's talk in Washington about privatization of Medicare and Medicaid. What do you think of that?
Yeah, I mean, I will tell you that's a difficult question. If you look across the world, Medicare itself is an actually relatively efficient system. And it does a good job with cost control, and it does a good job of funding itself, if all things considered. I think if you look at the Medicare Advantage programs across the country and what's going on across the country right now with Medicare Advantage, that offers you an insight into what would happen if you begin to privatize that. And what that does is it basically takes more money out of the care of the patients and puts it in the hands of an insurance company or something that may or may not be using that for the care of the patients. They may use that for quarterly profits or what have you. And that's my worry about privatization is that you begin to lose the safeguards and controls that are in place. And it all sounds good until, the bill comes due. And the bill always comes due. And if those dollars don't stay in the system, then the question is where are they coming from? And they're either coming from the patient's pockets or they're coming from the hospitals. And if they're coming from the hospitals, and I use that as the healthcare system, then not all of them will be around because they won't be able to afford this, and that will close, which will limit access. And I think that's always that tripartite problem you run into is access versus cost versus healthcare availability. And I think that's a big question that we have to answer still.
Now, Medicare Advantage, left to its own devices, will eventually bankrupt the Medicare Trust Fund. We've talked about that on this program on more than one occasion. And one of the things we learned was that this is self-inflicted. It was CMS that came up with Medicare Advantage, which when I'm not pounding my head against the wall about something that stuff is going on, I just the fact that they actually initiated this, I just think is a remarkable thing.
Mm-hmm.
Let's change the subject just a little bit. We all agree that Medicare Advantage is not working.
All right, go
and
ahead.
the only
Shane.
thing is helping is the insurance companies.
Yeah.
What about the recent development on defunding and changing the structures of NIH, which, if most of our audience probably doesn't know, is the best and basic insurance or a basic research institution in the entire world? What would happen if we continue to diminish NIH?
Well, and again, I mean, there's a lot to break down regarding the research, so I'll put my research hat on. A lot of the medical breakthroughs that are happening around that happen in healthcare that help people around the world occur within the United States, and they occur for multiple reasons, and some of which is related to the research that's sponsored via things like the NIH. And I understand it. When we start talking about the only so many dollars to go around, and we have to begin to live within our means. I get that argument completely. But we then have to ask ourselves, well, what do we do with a thing like the NIH? And what do we do with something like NASA, for example? And I use those two because they're, in general, considered scientific organizations. Is it a priority within the United States to try and increase and improve the healthcare of the folks that we serve? Is that a goal of ours? And if it's a goal of ours, we need to find a way to allocate funds appropriately to make sure that happens. Now, what does that mean from the research side? It's a great question. And I think, it's not as simple as saying, hey, I'm going to sign a contract and do the research, because as we all know, research is more likely to fail than it is to succeed, right? And the answer is that this didn't work. But when you're pushing the envelope and trying to really impact the care of folks, not just in the United States, but everywhere, that's often going to be the case. And the great part about the NIH and some of the stuff that's done there is that, it's open research. It's not a controlled product that has to be, monetized after the fact. It's that I'm going to find a better way of doing something and I'm going to help someone, or I'm going to find a better chemotherapy regimen. And I'll use the NCI, the National Cancer Institute, as a great role model for this. And the answer becomes is that, okay, well, I don't know if this cancer chemotherapy regimen is better than the other. So we're going to fund a study and figure out which one better treats breast cancer, for example. No one's going to do that outside of the National Cancer Institute, because there's no real reason for a drug company to try and figure out if theirs is better, worse, or the same. They just want to sell the medication. And so it's things like that that get lost if you reduce the funding to the NIH in the care of those patients, because there's always an ulterior motive to it. And with the, with the NIH, it's simply about the science and stuff behind it. Now, monetary wise, there's all kinds of questions regarding how the research funding is used. And I fully understand that we probably need to be better about transparency in the money. We also need to be better about stewardship of that money and making sure it's going to the proper support of research and things along those lines. I get that. But to say that we don't need the NIH or we want to defund the NIH is, again, it's a short-sighted answer to a problem that is not going to go away just because you get rid of the lens that you're looking through.
Let's kind of move back to Louisville a little bit. We've had Keith Miller on here a couple of times, and during one of the programs, he had mentioned, without getting into too much detail, that the trauma service had some sort of working program with the West Louisville to residents of West Louisville to reduce gun violence. Now, I don't know if this is a fair question to you, but is this something you could talk about in a little more detail so some of our listeners would have kind of a sense of what exactly is going on there?
Yeah, so
Great, good.
really, we've got a couple different things going on. So I'll put my trauma surgeon hat. I get to wear lots of different hats today.
Okay.
So I'll put my night and weekend being a trauma surgeon hat on. We've got a couple different things we do to work on gun violence within the community. The first thing we have is in partnership with the mayor's office and the Office of Safe and Healthy Neighborhoods. We got a program where we use our community health workers to work on violence interruption. So if someone comes in with a gunshot wound, stabbing, assault, things along those lines, interpersonal violence, wherever they are, we have someone that can go into the neighborhoods and talk to folks and find out what's going on, to try and calm the situation down so we don't get retaliation, to help improve, communication between, those involved in the hospital, and you name it, as far as trying to assess and de-escalate the situation around that. And that's been effective. I mean, I think that's one thing that we don't talk a lot about, but that responding to the incident side of things has been effective for us in reducing some of the violence that we often seen following an assault, a stabbing, a shooting, and things along those lines. The other thing that we quickly realized is that we need to begin to disrupt this cycle that we've gotten into. Not just, it's not just in West Louisville; it's all through Louisville, around interpersonal violence. And one of the things that we focused on early on was kids and those affected via violence. And so we saw kids who may have been a victim of violence, but moreover, that their family was a victim of violence. And you realized how they feared the hospital because the only time that they have seen a doctor or a nurse maybe has been to tell them that a family member was shot or died or they were involved in everything that was going on at the hospital at that time. And so we developed in conjunction with numerous partners in the community this program called Future Healers, which Keith Miller helps run. And Future Healers is the idea that we want kids to see healthcare and the hospital in a more positive light than they were exposed to. And so they started with 20 kids. They brought them in and let them talk to nurses and radiology techs. They took them to the hospital. They did activities with them about healthcare literacy and eating well and exercising and why tooth care is important. Well, you fast forward about 7 or 8 years, and through a lot of people's work, now we're sitting at 120 to 150 kids coming in as part of this program. They're rolling it out to JCPS and surrounding school systems to be part of the schools and working with them on this. They've exported this to Nashville and Cincinnati and Pennsylvania to start developing a similar type of program. And the idea is that now we've got kids that have started this program and they're through high school. Some of them have gone through our magnet training programs at Central High School here in Louisville, and are coming back in and working in our hospital system. And they're being advocates for healthcare in their own community. And they're telling people that the hospital and healthcare is not a bad thing. And from that perspective, it warms your heart to see that because that had not been in place. And it gives you the idea that with enough, long-term sight and effort, maybe we can make an impact on some of the things that we're seeing. And it's not an end all be all, but it's a start. And I think, that motivation to start and help folks is what, a lot of people need to take out of this is that I don't need someone to come in with sweeping changes that think that you're going to fix everything. Find a thing and let's work on fixing that. And sooner or later, we'll have the problem licked.
I'm actually scheduled to bring a busload of kids from Taylor County and Campbellsville High School up to the U of L in the next month to tour the School of Nursing and the medical school. And maybe in the future we could talk about getting our kids in Taylor County involved in a program like this.
Oh, yeah. Well, and I mean, we've now got this program at JCPS. We've got a program with Arvin, which is the Arvin Center, which is with Oldham County Schools, which is their healthcare kind of magnet where they've got some nursing students. The Arvin Center's great. They've got a lot of technical programs, but they've got the healthcare program, and they come down and rotate in our system as well. I'll be honest, I had the opportunity last week to speak at this organization called HOSA. It's for high school students, Health Occupation Students of America. And they're all high school students from around Kentucky that are interested in careers in healthcare. And they're not just doctors and nurses. Some want to be dentists, some want to be medical technicians and things like that. There were 2,500 kids here from around the state in Louisville that spent a weekend exploring and talking about being, what healthcare professions might be like in the future. That's phenomenal. For a state like Kentucky to have something like that is phenomenal. And to be part of that, it was great to see those kids because I think sometimes you lose the focus of being out. But it was great to interact with the kids and how excited they were. And it was a really cool part of what I think Kentucky could be if we just put some effort into it.
Well, that's really impressive, and I'm really glad that our listeners get to hear about that. Jason, I want to put you in a different corner again, this may or may not be something you're comfortable with, but I'd like to ask your thoughts about how the restrictive abortion laws in the state of Kentucky. The legislature, in its wisdom, has made some changes to that in the current bills. I don't know where it is in terms of its passage, but with these restrictive laws, my understanding is that the American College of Obstetrics and Gynecology requires that the residents have some training in doing abortions and the issues of the complications of pregnancy, which are restricted in this state. And it's coming. The side effects of that are, one, there are fewer. Again, my understanding, and I'm not sure if I'm correct about that, that's why I'm asking you. One consequence is there are fewer applicants for OBGYN residencies. Two, there are fewer people coming to Kentucky to practice obstetrics and gynecology, and the existing providers are either starting to retire sooner or moving to another state where they can practice appropriate obstetrics and gynecology and not be restricted by all of the issues related to dealing with the complications of pregnancy. So I'm going to I'm going to leave you with that. If you're not comfortable with any of these things, just let us know. But I'd be curious to know, from your standpoint as the chief medical officer of UofL Health, how some of this stuff is playing out there.
Right. Well, no such thing as a loaded question, correct? So,
you can handle it. We've got.
yeah. Well, and I can answer some of it. So, first of all, I can't tell you what it's like to practice at as an OBGYN right now. I don't. I wouldn't even know how to begin to speak for them. So let me be clear: is that I'm sure that they're going through a lot, and I think I remind folks that the people that go into this field of medicine, and no matter what field you go into, they ultimately take on this role because they want to help people. Otherwise, we would all take different roles and have easier lifestyles than we currently have. Now, regarding the training, what I'll tell you is, U of L continues to match well into our obstetrics and training program. I can't say I know what the actual number of applicants were this past year, but they did match well in that. And I'll tell you that over the last couple years, because of all the issues this has brought to the forefront, you've seen a huge increase in the number of students wanting to go into obstetrics and gynecology. And more so, I think they go into it as seeing they need to be advocates for women's health. So I applaud them in that. I think that is different than it had been many years in the past. And so I only know locally that one, we continue to match well, and two, we continue to put a lot of students coming out of our class into OBGYN. The biggest question I had, from a healthcare perspective is when a lot of these things went down regarding, legalization of abortions is one, U of L Health does not perform elective abortions. We never have. And so anything we do is medically necessary. And I will be honest, the state has been good about trying to identify those folks that need this and providing that care and providing that coverage. The biggest issue is when it first started is that there was so much going on. It was very difficult to figure out what was the actual legal standing because there were competing laws, and we're still working through a lot of that, which I think has led to the uncertainty in the overall healthcare world. Is that what can or can't we do? I think almost all physicians are willing to follow whatever rules you want to put in front of us as long as we understand what the rules are. And I think early on, that was the biggest problem we had. It was just so hard to figure out what rules we were supposed to follow. And again, the state has been good about trying to work through that. The state has been good about trying to identify what medical necessity is. And as long as we're protecting the physicians that are trying to do their best for the patients, we're willing to work within any rules put forward. But remember, the patients and the physicians are trying to do their best in a very difficult situation sometimes.
Can I ask?
Gene, just
Yeah,
for
okay.
1 second, I'm going to let you go. This is a 5-minute warning, so we're getting down to the last 5 minutes. Go ahead, Gene.
Currently, what does the OBGYN department do with complications of pregnancy? For example, ruptured membranes in the second trimester, or a lady that has a fetus that's not viable, like an anencephalic. That means the baby has no head.
Or an ectopic pregnancy.
Right.
Yeah, so I mean, I think there's different rules for all of those. I don't know them off the top of my head. I know that we gave some guidance, and our physicians have given guidance on what we would do in each one of those. Ectopic pregnancies we still see and take care of on a daily basis. Those for those that don't know, those are the pregnancies that don't implant in the uterus, and so they're not going to develop. And so we do see those. They can cause all kinds of surgical problems. They can cause the death of the mother. So there's lots of things that are going on. Again, that's my one thing is clear guidance. And I think that's where you get into issues with a lot of those areas is that I don't know the answers personally. Maybe our providers do, but they become difficult situations if you don't know what you're supposed to do.
I would mention that there was a bill before the legislature to try to define what to do about the complication of pregnancy, but unfortunately that bill did not come to the floor of the Senate or the House.
Well, listen, guys, we're getting to the 3-minute warning here. Jason, I want to thank you for all of us. This has really been a good conversation, and I want to compliment you and the U of L Health, everything from President Bendaputi getting the finances to this, to the way you all managed incorporating the other members of Jewish and St. Mary and Elizabeth into the system. So this is a real credit, and it's a good example of how a not-for-profit system can work for the benefit of not just the patients, but the providers and the system as well.
I would like to thank U of L Health for the last 46 years since I've been in Campbellsville. I've always had a close relationship with the Department of Surgery, and they've helped me numerous times. Patients that I couldn't take care of, they were glad to take, and we had a great cooperation. I really think that's very, very important for someone practicing in a small hospital in rural Kentucky.
Yeah, Jason, you want to make any quick last-minute comments, and then we're going to shut this off.
I've probably said enough today. Thank you, gentlemen. I'm glad to be on the program and appreciate it, and always appreciate the support and that you've shown us over the years.
Thank you. Paul's going to take us out.
Yeah, Jason, I thank you for coming on the show. And listeners, thank you for tuning in. And don't forget to go to forwardradio.org and hit that donate button so we can get the funds that we're going to need to keep us on the air for another year. Have a good day.